Well, we have made one.
I hope it was short.
It's short-ish. It's short. Considering your career, it is short. So I wanted to welcome everybody here. This is a meeting for the Substance Use Program on Research, which is one of the subcores for the Center for AIDS Prevention, Center for AIDS Research. Look, my mind is like terms. And we are excited. I'm really excited and thrilled to welcome Dr. Kimberly Page, who is an infectious disease epidemiologist who trained at UC Santa Barbara, North Texas University, UC Berkeley, and UCSF. So it's great to see you back at UCSF right now. Her research has principally focused on epidemiological and clinical studies of HIV and hepatitis C in high-risk and underserved populations, especially people who use drugs. She leads and conducts the collaborative high-impact research in New Mexico, the US, and internationally with high-risk vulnerable groups that may be medically underserved, who experience stigma, social stigma, and the associated social exclusion, including people who inject drugs, sex workers, incarcerated populations, and low-income men and women, and men who have sex with men. Dr. Page was a faculty member at UCSF for 20 years before joining the faculty of the University of New Mexico in the Department of Internal Medicine, Division of Epidemiology, Biostatistics, and Preventive Medicine. In 2014, 10 years, hard to believe. Today, she is going to talk to us about her work on the UFO study, and I'll let you tell people what that means, Kim, which is the only prospective cohort study of young adults, people who inject drugs in the US. And I'll turn it over to you. Welcome, everybody, and thanks.
It's very cool to see some very familiar faces. Hi, George. Hi, Peter. I haven't met the rest of you, but it's wonderful. Oh, Jennifer Cohen. So I'm sure we'll have people joining here in a minute. And you know, I'm sometimes calendar challenged too, late. I got on at 2 o'clock today because my brain wasn't yet switched to the time change and no one was there but me. And then I went, oh, it's not until 4. That's good. It's a pleasure to be here. Thanks for asking me to present here. I think there may be some wonderful opportunity for input from some folks who are attending, which would be really good. I'm going to share some slides. It's going to be relatively short, I think, and hopefully we'll have a chance to talk about what's happening overall. So let me get to my slides. So is everyone now everyone here is a Zoom jockey now, right? So we shouldn't have any problems. All right. Yvette was like, oh, I need a title. So I just thought 17 years and then what happened? So I was at UCSF. However, I was only a faculty member for 17 of those years because I had a 3-year postdoc. So I was there for 20 years, but 3 years as a postdoc in the Center for AIDS Prevention Studies, and then working with George in the Department of Epidemiology and the Global Health Group. Wonderful stuff. I moved to the University of New Mexico in 2014 to try a leadership opportunity. I really like leadership, but I don't like administrative leadership. I like to lead research. So I'm no longer a leader in administration. And all I do is research, and I feel like a kid in a playground. So it's pretty great. So I'm going to do a small overview here. I'll start. I have no conflicts. Oh, the meeting's being recorded. I can click OK. How's that? No conflicts. And I will start here in the beginning. So in the beginning, we were funded by a very novel research program that, and I want to bring attention to this because I feel like this is a really important circle. the university-wide AIDS research program, which we used to call the UARP, in 1998. So back when I was a postdoc and Peter was in grade school, I'm sure. The UARP funded collaborative research, and the researchers at the universities had to collaborate with a community partner. I think that the advent of community-based and community-engaged research, for me, this is where it started. And that beginning was really fantastic. Many of the lessons that we learned then still apply now. And we partnered, those of us in epidemiology and biostatistics, well, we had people from all over, partnered with the Haight-Ashbury Free Clinic, and they had the Haight-Ashbury Youth Outreach Team. And these names, myself, Judy Hahn, Kristen Ochoa, Rachel McLean, Paul Alum, Jackie Tulsky, and Andrew Moss were sort of the beginning. And if I was to show this, you can imagine what it would look like if every person brought 2 more people in. That's how it grew every year. It was a snowball effect. And back in 1998, HIV prevalence was 6%, and a sample of 300 young people who injected drugs. They were all under age 30. But hepatitis antibody was prevalent in 45% of people. And this is not relative to some other groups in San Francisco. 6% was not very high, but you have to remember these were all very young people. And our median age was 22, if I remember right. But almost half of them had been infected with hepatitis. And so the UFO study really got a lot of its funding support for our hepatitis research, and HIV, there really just wasn't much of it. But everything we learned about hepatitis was really important for understanding HIV, prevention, treatment, and other factors. So we looked at how, at the prevalence of infection, which is here on the left, and the number of years injecting, and you can see the blue bars, which show hepatitis C prevalence. If someone had been injecting for 10 years, 9 or 10 years, the prevalence was over 70% for 10 years or more. So, but HIV was pretty stable. People were getting infected, not so much in the early years, but later on in their injecting careers. And very early, I wanted to write something about, well, first they get Hep C, then they get HIV. And Andrew Moss wouldn't let me because he said I didn't have the data, but I think we did. We were able to show that risk factors for HIV and hepatitis C were very different in people, young adults who injected drugs. And I'm going to call them, well, I don't really like it, but I might use the word PWID, so just forgive me. Risk factors for hepatitis C were really mostly associated with injection exposures. How long they've been injecting, how long they've been in San Francisco, if they injected with a sex partner, borrowed needles or other injecting equipment, and snorted cocaine, meth, or heroin in the last year. I'm sorry for the non-lineup here, but this was a huge difference from what we saw for risk for HIV. And risk for HIV was really concentrated in men who had sex with men. So they identified as homosexual and bisexual versus heterosexual, and the risk was the odds ratio was 7.5 to 1. So that's 750 times. And if they'd been in San Francisco, the longer they'd been in San Francisco. Back in 1998, we were recruiting at Polk Street, which was really, I don't know, I haven't been down there in a while. It might still be the same. But anyone we recruited from Polk Street was also at higher risk for HIV. And we really figured out early that HIV was associated with sexual exposures and hepatitis with injection exposures. And that's, but we had to kind of study both. After the UARP grant, we got funded by NIDA, and we were funded from 2002 to 2017. literally for a constellation of studies. So this was three grants. We were renewed for a third time through 2017. And this is what my desk looked like. And Peter's desk too, because he was the project manager for a lot of this. And we've had many postdocs and residents and young and many investigators with whom I still work with involved in all of these studies, including of novel testing approaches for hepatitis, incarceration risk. We showed was associated with double prevalence of HIV in our injectors compared to those who had never been incarcerated. And it was actually quite similar for hepatitis C. People with a history of incarceration have higher risk. We studied overdose, lots of different other factors, mortality, and eventually I am very proud of the translational next steps that we took, which was to test a vaccine for hepatitis C. I'm still involved in some vaccine research, and I just love vaccines. So this was published in 2018 by Ali Mirzazadeh. It was in 17 in EPUB. And we looked at data from 2000 to 2014 for HIV incidence. What you can see is that it was pretty kind of stable, if you will. We had a little uptick in incidence in 2003 to 5, but very important for those of you who aren't epidemiologists and who are, these are very small numbers. Very small numbers. And so our confidence intervals are very wide, but these numbers are telling. One of the things I like to remember about this data is that of the 9 men who were infected over the years, 8 actually were men who had sex with men. So that told us where HIV was happening. The truth is there's very few studies of HIV incidence in people who inject drugs. And so I was kind of like, well, I wonder what people are doing now since the cohort shut down. This review looked at data from 2000 to 2021, I think, or 22. And there were maybe 8 studies in the Americas that looked at incidence, and they were conducted in New York, Baltimore, Chicago, San Francisco, and San Diego. And that's it over all of those years. So our study really was important for that era. And but what they found here is similar to what we found, which was that age was associated. You saw differences in age and incidence of HIV, differences by network recruitment and community recruitment. But the most telling one, I think, and I want to come back to this, is the risk of HIV in association with the background prevalence in the population. And what this shows is that if the prevalence is less than 5.3%, incidence in this meta-analysis was 0.7. And the confidence interval is to the right. And these are all different prevalence rates. You can see it rising, and there's probably some kind of a threshold effect here because once it gets over a certain amount, it's very, very, very high risk. We haven't seen prevalence of HIV in the injecting population above 2% in a long time in the United States. So let's remember that for a question I'm going to bring up later. This data shows that overall, HIV has declined in people who inject drugs. It's been since 2007. This is CDC data. It's been, they interpret this as stable. 2020 was kind of a weird year, as we all know, and 2023 data is not available. But it really hasn't changed since 2018. And since 2018, steadily, 7% of people with HIV attribute it to injection drug use, and 3% male-male sexual contact and injection drug use. This male-male sexual contact and injection drug use did decline 10% between 2018 and 2022. I think prevention works, but I can't help but wonder if we have this sort of endemic situation, not in the US, not unlike what we saw in our UFO data in San Francisco, where it was quite stable over all of those years. This shows you too the incidence by year, by race, ethnicity, and gender. And the trends are the same everywhere, but most importantly, it's going down in our minoritized populations, which I think is very important because they've always had a disproportionately high risk. So that's good news. So what's changed? Well, what's changed since I moved away from San Francisco? When I left San Francisco in 2014, we were starting to see fentanyl. And, you know, there was the East Coast had seen fentanyl, the East Coast, it was this crisis. Everyone was sort of in crisis mode. This is going to happen. And we were thinking, no, it's not going to happen. We have black tar heroin. Who would mix that in with black tar heroin? Well, San Francisco started seeing fentanyl. And in 2014, when I came to New Mexico, we actually didn't have any fentanyl here. And I still believed, no, we're not going to have it because, you know, we're like the capital of black tar heroin. And now that's all we have. Fentanyl and other opioid analogs, the drug supply has changed. It's very important to remember that drug use is completely driven by the drug supply, right? So what people use is based on what the market offers. So not only do we have fentanyl and several other very dangerous opioid analogs, illicitly manufactured analogs, we have a lot of contamination and counterfeit pills, and we're seeing some transitions from smoking to injecting. And I want to really give a shout out to San Francisco researchers, Alex Crowell and Peter Davidson, who's here, who work with several folks and who have been doing the groundbreaking work in this area. Transitioning from injecting opioids to smoking, that San Francisco first published that, I heard about it and I thought, wow, really? Well, it turns out fentanyl's not really very easy to inject, and it's very easy to smoke, and you get a really quick high. And that group has also gone on to write about the health risks associated with smoking. Just to highlight a few things from this work, and Peter, you can correct me if I get it wrong. I have some notes, but the number of injections decreased significantly among people who inject drugs from 2018 to 2020. And people who inject drugs that had fentanyl in it, the number of days they smoked fentanyl increased. They found that people's main motivation for switching was related to difficulties in finding easily accessible veins. But I can't help but think that there's more to it than that, because it is hard to inject. So they probably go together. And after switching to smoking fentanyl, they reported that people began noticing many benefits, including how the drug felt, improved health, fewer financial constraints, and reduced stigma. So that was the injection part. However, people who injected fentanyl were 40% more likely to have overdosed. People who injected fentanyl were over 200% times more likely to have had an abscess. And emergency department utilization was the same for both groups, but people who used fentanyl, injected fentanyl, spent more nights in the hospital on average. The thing is that the attributable risk now is changing for smoking fentanyl. And so what are the health risks associated with smoking fentanyl? These are things which, again, Alex Crowell and his collaborators published this. These health risks are really important because it's a whole new ballgame out there. And if I remember right, because I don't think I have, I don't have a note for that one. There was, I just gave them to you, the hospital stays. I just read them. So forgive me. So I think this is a big important thing. We now are seeing in New Mexico over the last 2.5 years, 3 years, what, you saw in California 8 years ago. So we're about 5 years behind. I've heard that you can't even buy it, but it's really hard to find black tar heroin, even up in Espanola, which is quite the center. And we recently did a study of, we sampled 100 people who use drugs in Albuquerque, 100 people who use drugs in Espanola, which is up in one of the counties. It's a rural area. And we also have a collaborator in Nevada, Carla Wagner, and they did the same with this study is with them, did the same in Reno and Las Vegas. And so we have 400 people. And the health risks associated, I mean, fentanyl was front and center in terms of opioids. And interestingly enough, across both states, 96% of those people that we sampled were using methamphetamine also. Poly drug use is not new, but it's getting a little bit more attention now. And so that'll be an interesting and important thing to look at in terms of changes. The changing in injecting versus smoking was also shown by this group from San Diego. And I think this is a really great figure. They show over time from 2020 to 2023, the proportions of people who only injected or who only smoked or who injected and smoked. And that blue proportion there has risen by 100% in just a few years. So smoking is what's happening now and less injecting. So for thought and discussion, yeah, I'm going straight to the heart of things. So we see many of the same things that you see in California. We see them in New Mexico and my colleagues in Nevada. I'm the PI of the Southwest Clinical Trials Node for NIDA. So we actually get to interact with nodes across the country. And many of us are facing all of the same problems. Our clinicians are looking for the best ways to give folks treatment for opioid use disorder. There is a huge need for treatment and I'd say harm reduction for methamphetamine. Methamphetamine's back. It cycles through like everything else. Oh, by the way, here, one thing that we do have, I don't know if you still have it in San Francisco, half of the people who use stimulants here use cocaine. Cocaine's very prevalent here. I first want to go back to the prevalence and the background prevalence of HIV and risk. PrEP is highly effective for preventing HIV infection. Recommendations from CDC and WHO are basically to offer it to anyone with sexual risk and people who inject drugs who report unsafe injection practices. And given what you saw about prevalence, PrEP is underutilized by people who inject drugs, and it's underutilized by younger people who inject drugs and also by minoritized people who inject drugs. Do we need to worry about that, especially given that background prevalence is low? And this is a question that I keep asking myself because I keep reading crisis things. Everyone needs to be on PrEP. And I wonder about the risks and benefits of that, given that there are risks associated with it. And when background prevalence is low, should we be offering it? And I'll just take the slide down now if we want to chat about that a little bit. If you're an epidemiologist, you probably love that question. No thoughts?
Oh, everybody has a million thoughts. This is George.
Come on, say them out loud, George. I really want this to be more interactive.
It's great to see you.
Yeah, nice to see you.
And PrEP is for sexual risk. I mean, there is the one trial in Bangkok that looked at injection, but as you say, as the prevalence drops, the risk comes down. And I mean, the real key here is getting people identified and treated not only for their HIV, but also treated for the hepatitis C. And I think that PrEP is, with the adherence issues, unless we can use cabotegravir or something, the adherence issues is probably a fairly distant second or third choice for prevention at the population level. I mean, sure, for gay men, it's number one on the hit parade.
Number one, I agree.
But for this non-MSM population, right? I think it's, I think there are other things we can do.
Your and my thoughts might be considered controversial. I'd love to hear from someone who thinks differently. Milo?
Hi, Kim. Welcome. Thank you for joining us. And apologies for being late. I'm teaching a class right before this. I will share that for the National HIV Behavioral Surveillance Survey among people who inject drugs, there was we collected information on the PrEP cascade, including knowledge of PrEP and interest in PrEP. And there was a substantial proportion of people who inject drugs who were interested in PrEP. But the important thing to note is the uptake is low. So between the folks who are interested, there is like a different gap between those who are able to get PrEP. So I feel like at the very least, we're not meeting the needs and the desires of those folks who are interested in getting PrEP. So there is like some barriers that we need to sort out that are unique to people who inject drugs.
I believe that the NHBS data shows that 33% of HIV uninfected men report having unprotected anal sex with an HIV positive or unknown partner. So we still have high sexual risk. And while even higher proportions of people who inject drugs report sharing equipment, we're looking at 77, 79% equipment in general. We don't see the same thing. So I think it's, the probability of encountering an HIV positive person on the other end of the transmission chain is really low for people who inject drugs and aren't having sex with men, who aren't male and having sex with men. No one else wants to jump into this controversy?
I mean,
we must not have very many MDs here, because MDs love to prescribe PrEP.
I mean, I can throw in that at least in California, there's a lot of variation in what's acceptable as an intervention in different parts of the state. And the HIV rate amongst people who inject drugs in Orange County, for example, is about 13%. And there's—
Is that prevalence, Peter?
Prevalence, sorry. And the politics around providing needles is nightmarish. So going to Orange County council members and saying, well, that means we've got to put everyone on PrEP instead is at least politically useful, even if it isn't necessarily as realistic as we might want it to be. But
that's a good point. I think that's a really good point.
I'll add with that fentanyl paper, one of the other thing that came up in qualitative data for reasons people switched from injecting to smoking is that it lasted longer. And if you're trying to stay well and avoid dope sickness, then having something that doesn't take off like a rocket, but then drop like a rocket straight afterwards is—
right. Injecting, you reach the half-life much quicker.
Yes.
Yeah. It's a really good drug. I had a surgery. I was like, yeah, I'll take fentanyl. It's a really good drug. So
Kim, I have a response to what your question was, which is, I'm not an epidemiologist, but as a clinical person and nurse, I think it's hard to give those kind of messages in clinical practice because people don't always, it's like they don't want to err on the side of somebody, there's going to be a bad outcome, right? And I think that's just kind of how people are trained to give sort of more black and white messages, for lack of a better term. When I was working on a study where we're trying to do behavioral change with clinicians to talk about risk behavior, people were very uncomfortable with the whole idea of harm reduction. right? Like you could, and it's just like, it's just not how people are trained historically. Maybe that's changed now, but I think it's like trying to get all the information to the people that are in front of individual patients to be able to have that kind of a perspective can be challenging. That's one of the things I've learned.
Do you think that providers or, do think also though about this risk benefit ratio? I think that may be missing from this picture because there are risks associated with that versus potentially no benefits. Although it varies a lot.
I mean, yeah, I'm not the expert on this, but one of the things that I would say is that thinking about a clinical interaction and the structural framing of those clinical interactions from our payers who are saying this is how much time you get and this is what you have to do can interfere with that. And so that's the kind of environment you're trying to go into, which I think can be challenging for people. Because I agree risk benefit for sure, but this might not be at the top of the list for risk benefit conversation. This is just my opinion. That's not based on any data, but
I think it's a great question. And I think this could be very interesting research for someone who is so inclined. Let me go back to my next sort of thoughtful discussion point. So with the changes in drug use from injection to smoking, definitely there's a recommendation that we should have safe smoking technology or modalities in harm reduction services. And I wonder, will we see a drop in the incidence of bloodborne infections with the shifts to smoking? Is anyone researching that? Not that we know of. I think this would be a really great research topic too, is to find out both among people who started injecting and stopped and people who started smoking. Because you still have other forms of risk like sexual risk, etc. But I wonder if we can't maybe see that bump go down, that endemic rate, if we see if this population level, and remember in San Diego, the rise was over a third of people were then only smoking. So, and if people reduce injecting and smoke a little on the side, maybe that can also be a risk reduction. How should we study that? And what do you think?
I think that your point about what's available, so, this is market driven, is also important to include because there are trends that change over time. So, we can't assume that this is going to be static, these changes from injecting to smoking. And if I've got the acronym right, the UFO stands for You Find Out. So
I'm coming to that.
You are? Okay, good. So I was just wondering if your initial intent was early identification, then it's really down to personalizing the education and the intervention.
So in 2022, the federal government decided that they will not fund safe smoking supplies. This is something that hasn't changed. The federal government still doesn't support state-of-the-art prevention. Sometimes we find ways to get around it, or people do. But if people are smoking and we want harm reduction to continue, why not? Peter, what's involved in the safe smoking supply needs of people? What kind of equipment do we need to be giving out?
Basically just pipes and Brillo. I mean,
Pipes and what?
Brillo.
And maybe a little tinfoil.
And a little tinfoil. But I'll throw in that we're and foil, yeah, Laura. I'll throw in that the drug market is changing fairly rapidly. I mean, watching testing here in LA of what people are bringing in for testing, we're already seeing opioids back to 40% heroin. I don't think I'd want to write the grant to study the impact of changes in switching to smoking fentanyl, because you might not have a study population in 2 years.
Well,
Here.
again, there are some places that are 10 years behind.
Absolutely.
Right. Yeah, but it's important. So that pulse that we see on the East Coast and with drug availability is really changing. Another thing that's changed, let's see, there's something in the chat. Oil, yes. Anyway. So no one wants to take that on. I still think it might be a worthwhile study to look at differences in prevalence of bloodborne infection in people who smoke and don't smoke, because you could use those results to try to, I'm hypothesizing that there could be a decrease in bloodborne and sexually transmitted infections with smoking. And so I think that if we could show that, it would maybe support providing prevention for safer smoking supplies. The other thing that hasn't changed is stigma. That still remains a very important factor that is highly associated with risk, and that really hasn't changed. Some of the folks who switched to smoking said that they experienced less stigma. Another thing that hasn't changed is we still have an ongoing epidemic of fatal overdose, and even though opioid prescribing has gone down, we have a significant mortality associated with the increased risk that we see with fentanyl and these other drugs, and the polydrug use with methamphetamine. All of my partners, the whole UFO gang, were let note of that we were doing this. We had many, many wonderful participants. We had amazing community partners, and we had 15 years of grant support from NIDA. The big lessons that I took away from doing UFO are really how I do research still. I just finished a study of a survey of 532 people experiencing homelessness in 10 counties of New Mexico. How did we do that? With 10 incredible community partners who we promised, who were very involved in picking the survey. Margot Cushell gave us a bunch of great information, and we adapted it here with our community partners. They got their own data, they got regular updates, they're participating at a high level, and they got money from the health department to do it. Money is important for your community partners. And it's like brought me back to my postdoc days there in San Francisco when we were on the street in the Haight doing this with our community partners. And so in that sense, not much has changed. I still feel like it's what, it kind of lights me up. I love a good clinical trial. Give me another vaccine to test, I hope soon. But the community engaged research that we do for these things with people, I think, has been the most rewarding. That's really all I have to tell you. I think you probably all know more about what's going on with HIV in your area, but it's nice to hear a perspective from somewhere between Baltimore and San Francisco. There's a whole world out here, you guys. So I'm going to open it up to questions, comments, good jokes, and discussion.
Thank you, Kim. There are a couple of questions in the chat or comments in the chat. I don't know, Natasha, if you wanted to come off mute and ask or make your comment.
No, I was just going to say thank you. And it was an old comment as you were talking about sort of the market and variations. I used to work at UC San Diego, and I think that that region, although it's the largest populated region of the border spans, I think 50% of it is along Texas, right? And so that's where I study substance use now in El Paso and Ciudad Juarez. And
oh my God, I just read one of your papers. It's so good.
Oh, really? And so, yeah, we are anticipating fentanyl will come to us, but as of right now, the presence is pretty low. We've been doing test strips out there and sort of waiting and sort of, you know, educating people on sort of the risks of using fentanyl, but haven't seen it yet. And, you know, methamphetamine use is actually pretty low there too. So it's a whole different market.
Yeah, you know, I mean, if you're in epidemiology, we always say all epidemics are local.
Mhm.
And, you know, the way an epidemic progresses from everyone having it to small little bubbles, now we're all chasing small bubbles. So it does vary. Yeah. George.
Thanks, Kim. It's great to see you. And thanks a lot for your talks. You know, don't be a stranger. I was going to ask about Mexico as well. Do you see, I mean, I realize Albuquerque's 300 miles or whatever it is from the border, 290 or 280, whatever it is. But do you see much stuff coming from Mexico, or do you see stuff from the US going to Mexico?
No, we have stuff
which is
coming
low.
from Mexico. Yeah, it's all coming from Mexico here.
Uh-huh.
And bye, Peter. So nice to see you. Don't be a stranger, as they said. Actually, the two of us, oh, he's gone. Yeah, we definitely see stuff coming from Mexico. And I had a really interesting experience once. I came back to my office, and someone had left a note, and I still had it with a map. And it turns out it was a primary care provider in Kansas. And he drew me a map of how the drugs are coming up through Espanola, right up into Pueblo, Colorado, and going out to Kansas. So the highways, it follows the highways and the byways.
Thank you.
And I think that's where all of our cocaine comes from too. Do you guys have much cocaine in California on the border? We have cocaine all over the state, but really fentanyl is taking over.
I can't speak for San Diego anymore, but it used to be pretty low, and methamphetamine was the predominant stimulant out there.
Yeah. Again, over like 96% of our drug users are using meth in some form. And some of that research by Alex Krau's group on the transition also shows that some people suggest methamphetamine is increasing in order to deal with the very sedative effects of fentanyl. There's a lot of reasons people use drugs, but that's maybe one.
Joseph, did you want to ask your question that you have in the chat?
Oh.
Hi, my name is Jyoti. Thank you for a really interesting talk, Kim. I'm from the UK, so all of this is really very alien to me. But I just had a question around the HIV transmission, injecting and smoking. And you asked about whether it would be possible to do a study to identify the impact of transition to smoking. And if I understood your data correctly, the incidence is really low of HIV through injecting currently. So I'm thinking you probably need either very long prospective cohort or a very, very big, quite, large.
I wouldn't study this with a prospective study, but this is one of my favorite kinds of discussions. If you have a study question, how would you do this if you were going to do a prospective study? How would you do this if you were going to do serial cross-sectional studies or case control study? So think of all the different study designs and how you might study something using different designs. In this case, I would do serial cross-sectional work and really look at the association between the number of years of exposure, of the exposure of interest, and the prevalence, like we did back in 1998, where we showed, and then from that, we actually modeled what incidence was going to be from the prevalence.
Thank you. Yeah, I can see how you might do that.
I think interestingly, in the UK, where you have a real kind of feel for who are heroin users and who aren't heroin users, You could almost, almost have a cohort there, and you could do
Yeah.
you could do a nested case control study.
Yeah.
And look at people who seroconverted and or people who didn't seroconvert. Probably
Yeah, they have a
several
huge
different prayer.
registry there.
And you might be able to fish it out of that pretty efficiently.
Thank you.
So in in case people don't know, in nested case control studies, you take all the cases. You have a cohort. So within a cohort, you take all the cases and then you sample among the people who aren't cases. And you can match or not match.
That's
whatever.
how I did the oral HIV study.
I remember.
My first grant, you guys, was oral transmission of HIV. So I just interviewed people who only had oral sex. But basically we did a nested case control. But yeah, because there's not very many.
You could also maybe include measures in like the medical monitoring project, which like surveys all the folks who were recently diagnosed with HIV and ask them about their smoking and injecting patterns, and see if there's a shift in like the routes of transmission.
And it may be possible to match up some ecological data. So you could use various different study designs to look at that.
Sufficiently?
Being such a teacher. Sorry, go ahead, George. Sorry.
No, I just said, have we confused you sufficiently?
I'm really not a teacher. People ask me, I don't teach much, but I love mentoring and I love this kind of interaction. So
of course.
I had to stop teaching when med students got mad at me for not providing snack in clinic.
Mm-hmm.
Yeah.
I think before we end the hour at 4, and switch over to the ESI folks, Claire, did you have one? That's quick. Thanks.
Thank you. Yes. Hi, I'm Claire. I'm a Epi PhD student at UCSF, and I work with Megan Morris, doing a lot of related research. And I first wanted to shout out that a lot of the folks that I get to interact with and our current study participants had really positive experiences in UFO, and I still hear about it all the time. Just last week, people talking about UFO and feeling a sense of pride that they participated. So just wanted to share that. And then also, this isn't directed maybe directly at you, Kim, but I thought this would be a good audience to ask if anyone was planning on looking into the impacts of Measure F in San Francisco, which just passed recently, and it's I can put it in the chat, but basically it's having folks screen and test for drug use in order to receive county funds. And it's going to launch, I guess, in 2025. And yeah,
that's very retrogressive. What do you call that? What's
very
that
much.
word, George? Very
Regressive.
So,
Regressive.
yeah.
As anti-progressive, but it's it's getting there.
yeah, so I'm stressing about this measure passing, and I just wanted to hear if anyone else was thinking about trying to capture the inevitable.
You've got some great policy folks over there.
Yeah, I was going to say, Laura, do you have any info on that? Oh, I see your comment.
So I've definitely been following the implementation of Prop F pretty closely, and it seems like despite all of the rhetoric from Trent Rohr at the head of the Human Services Agency, that the staff who are actually going to be implementing it are doing a much more sort of nuanced job of trying to primarily connect people to existing resources rather than a punitive withholding of benefits. So, because they actually care about the people that they interact with, as opposed to, the mayor and the head of HSA. But at any rate, I'd be super happy to have a conversation with anyone who's interested in trying to figure out what some research about that would look like, or even just kind of where the implementation plans currently are.
Thank you. I'm going to ask for your email in the chat then.
Well, it's nice to see you all. I'll be out and giving a talk in UCSF in September as part of the, what is it, the Max Wise cohort. So I'll be out there in September, and I'll look forward to meeting up with some of you.
Great. Thank you, Kim. And we really appreciate you coming. I do want to encourage, if there are any early stage investigators who want to stay and ask Kim any questions about not only her research, but her career, or we're open to that for the next
What am I on now?
30 minutes.
24 years of continuous NIH funding.